Good morning. Welcome to our grand rounds. So now it is my distinct honor and pleasure to introduce Dr. Thomas DeSalvo, who comes to us from South Carolina. He's currently the Professor of Medicine and Chief of Cardiology at Medical University of South Carolina in Charleston. So Dr. DeSalvo attended Harvard College and graduated with honors from the University of Cincinnati College of Medicine, and following medical residency and chief residency at Johns Hopkins Hospital in Baltimore, and serving as faculty at Johns Hopkins School of Medicine. He completed fellowship training in cardiology at Mass General Hospital at Harvard Medical School, which talking to him, he knows our Dr. McGillivray. After 10 years of clinical practice as an assistant professor of medicine at Harvard, he was recruited as medical director of Vanderbilt Heart and Vascular Institute and associate professor of medicine at Vanderbilt. In 2015, Dr. DeSalvo was recruited as professor of medicine and chief of division of cardiology at MUSC. Throughout his career, he is renowned for being an active and busy clinician and really committed to the highest standards of excellence. He is also known as an excellent educator, educating legions of physicians, students, and residents, and also committing time to spend time with patients and their families. Dr. DeSalvo is really well known in our circle in advanced heart failure for his research and its contribution in our knowledge base of the right ventricle, and in particular of physiology, how that interacts in our overall clinical practice. As you know, right ventricular failure is our Achilles heel. We deal with this every day. So we are very much looking forward to this lecture to helping us better understand, to bridge the gap in our knowledge of the RV and RV failure. So his talk is Assessment of Right Ventricle, Imaging, Hemodynamics, Implications, Management. Dr. DeSalvo, welcome.
Thank you so much, Dr. Park, for that kind and generous introduction. It's wonderful to be here, and I appreciate deeply the honor to present to you aspects of physiology as we get started of the right ventricle and hopefully beyond. You've done a wonderful thing in recruiting Dr. Park and actually Dr. McGillivray, who I worked with closely for over a decade when I was in Boston. So I think the future here is even brighter than it's historically been. This is what I'd like to try to cover. It's an ambitious agenda to focus initially on RV dependence on left ventricular function, the determinants of right ventricular function, some aspects about the development of right ventricular afterload or pulmonary hypertension, developing the concept that every right ventricle in both HFpEF and HFrEF is frankly at risk, with some evolving data, particularly in HFpEF, and then some tools for clinical assessment. As we get started, it's important to realize that the right and left ventricle have distinct morphologic differences. The right ventricle, shown in blue on the panel to the left, is a crescentic, non-ellipsoidal configurated ventricle. It has three anatomic divisions: an inlet region, a trabeculated free wall, an apical region, and an outflow tract that has an infundibulum that's highly contractile. Shown in panel B on this slide is as the right ventricle remodels itself, it dilates and assumes a different configuration, as does the ventricle, in this instance of biventricular dysfunction. As we'll develop, all these things have very important implications for the interaction of the ventricles and the right ventricular adaptation to disease. First, important to recognize that there are distinct comparative structure and functional differences. Some of this is belied by the fact that the right ventricle is derived from the secondary heart field embryologically, the left ventricle from the primary field. There's not been much differentiation in basic in vitro experiments between right and left ventricular myocytes. As we'll develop, the structural differences confer distinct functional and anatomic aspects to the right ventricle not shared by the left. First of all, the right ventricle shown here has about a fourth of the mass, about a third of the thickness. It develops obviously less pressure because it's designed to do high volume work, very responsive to minute circulatory demand changes with venous return. Its intrinsic systolic function or contractility is about a fourth of the left ventricle under baseline conditions because the resistance is about a tenth actually of the systemic vascular resistance. As a result, its stroke work index under resting conditions is lower, and its adaptation is described as to pressure, not volume work. Cardiodynamics are also distinct in the right ventricle. RV contraction is sequential and peristaltic rather than more uniform, longitudinal, and torsional, which is the case in the left ventricle. The right ventricle contracts from the inlet through the trabecular myocardium to the infundibulum with a delay. As the right ventricular is challenged with pressure or volume overload, it becomes more LV-like, but it never truly adopts the same temporal or contractile wave of propagation that the left ventricle does. There are three separate mechanisms of RV contraction: the free in-wall movement, which is mostly a transverse shortening, if you will, that has a bellows-like effect and is critically dependent, as we're going to discuss, on left ventricular septal position and contractility. The contraction of the longitudinal fibers contributes most to right ventricular ejection. That can be measured in TAPSE and other echocardiographic indices we'll touch on. And the traction of the free wall from the septal attachments is a critical component, as we'll develop in more detail. The shortening of the RV is much greater longitudinally than radially, and the torsional and twisting movements that mostly allow blood to be impelled from the left ventricle appear to be less important in the right ventricle. And that's because the heart has a helical three-dimensional array of fibers that confer different functions in different parts of the two ventricles themselves. There are two interconnected loops. This is the Torrent-Guasp model, a basal and apical loop. The basal loop has a transverse muscle orientation. It actually provides most of the RV free wall with the musculature. There are two limbs, ascending and descending, which are obliquely oriented of the apical loop. That forms a helix and confers circumferential fibers predominantly to the left ventricle. That comprises the LV-RV septum and the lateral LV wall. That's why the torsional movement of the RV is as prominent as it is, and that's almost passively translated to the RV to allow this sweeping peristaltic contraction to impel blood out of the right ventricle into this low impedance circuit. If we look at the determinants of function, the sarcomeres contract, at least in vitro, about 15%. The whole heart shortens much greater than that. It does so in part by harvesting this oblique orientation of fibers. RV and LV blood ejection occur primarily via twisting, via this septal fiber orientation, at least with respect to the RV. And that's the most important contribution to intact RV function over time. The RV free wall contributes less with this transverse motion, again, given to the layering of its fibers themselves. So if we look at that, this is one of many experiments that has been done actually using echocardiographic indices. The longitudinal shortening of the right ventricle accounts for up to 80% of RV function under normal physiologic states. As we'll see, that's altered in cardiac surgery and in most RV pathologies. Well, that's led to some interesting and unfortunately dead-end experimental avenues. This is a classic experiment, 1943, done by Starr and colleagues, where there was electrocauterization of the right ventricular free wall in dogs, and they found no increase in venous pressure. It turned out that they didn't find any change in right ventricular hemodynamics or venous pressure because the septum was left intact and highly functional. So even with, if you will, a non-functional right ventricle, as we'll see, there can still be ejection from the right heart under conditions of normal pulmonary vascular afterload, low RV afterload, and intact septal positioning. And this is a very interesting experiment where the two ventricles in dogs were electrically isolated. So there was left ventricular pacing performed. Again, this didn't propagate an action potential to the right ventricle, and there was right ventricular pacing performed, as shown on the bottom panel. When the left ventricle is paced without any electrical activation of the right ventricle, there's generation of right ventricular pressure and generation of pulmonary arterial flow. So much for excitation-contraction coupling. You don't need it in the right ventricle to have the right ventricle eject blood under conditions of normal right ventricular afterload. When one paces the right ventricle, there's no left ventricular pressure developed. Excitation-contraction coupling is critical to the left ventricle, but there is some ejection of right ventricular blood flow into the pulmonary artery. So at least 50 to 60%, based on this experiment, hypothesized, of RV contractility is actually generated by the left ventricle. An elegant way to demonstrate it by selectively pacing isolated electrically right and left ventricular experimental models. In addition to that, other models have shown that when the pulmonary artery is banded to create pulmonary hypertension, and then the aorta is banded, so both pulmonary and aortic banding, as you can see in this study, the right ventricular intrinsic contractility or elastance increases substantially with the addition of arterial banding of the aorta in addition to arterial banding of the pulmonary artery. In fact, it doubles without any change actually in aortic contractility or elastance in pulmonary banding alone. So more evidence of how intimately related these two ventricles are. Finally, important to realize there is a constant yin and yang in treating our patients given the importance of left ventricular septal function of the loading conditions of the left heart. And we're going to develop that concept in LVADs in particular. Normal position, and proper contractile function of the septum is critical to determine RV function. When the right ventricle is volume overloaded for any reason, and there's adverse ventricular interaction with leftward shift of the septum and hypocontractility of the septum, that's a very challenging hemodynamic state for the right ventricle because it's deprived of not only this torsional passive impelling movement that we described earlier, but it also has less traction of the RV free wall. So let's talk a little bit about that afterload dependence, and I want to segue after some general comments into some pressure volume loops, particularly for the fellows in the room, because I think it's helpful to drive the concepts home. Louis Delatale, who's one of the most thoughtful writers of right ventricular physiology over the last 30 years, has written that RV failure really only occurs under two general conditions. There's either excessive RV afterload or impedance, or there's LV septal dysfunction. Going back to that study in 1943 with the dogs with electrocauterization, if RV afterload is normal and LV septal function is normal, that actually appears, at least acutely, to be a relatively innocuous state. Well, what are the determinants of RV afterload? There's pulmonary vascular resistance, pulmonary compliance, which we're going to develop in some detail. But it's more complex than that because there are wave reflections that are based upon the anatomic distribution of branches in the pulmonary vasculature, and there's inertia of blood. All those things actually impact right ventricular impedance. RV contractility, as we developed, is due to unique aspects of anatomy, systolic interactions, intrinsic RV function. We're going to develop the concept of how that contractility is coupled to RV afterload, which is a major determinant of fate and function of the right ventricle over time in common cardiovascular diseases, both HFrEF and HFpEF, and a little bit of comment, particularly in surgery, about the pericardial constraint interactions. This is a classic experiment by Abel and Waldheisen in sheep with acute pulmonary artery afterload elevation. You can see that the right ventricle, unprepared, will actually show a marked diminution in stroke volume with a mean pulmonary artery pressure that rises abruptly. Very different than how the left ventricle can compensate. So no surprise, the right ventricle has a fifth of the muscle mass. It's designed for volume work. It impels blood with the assistance of the left ventricle rather than creating the circumferential wall stress that creates isovolemic contraction and ejects blood from the left ventricle. That's RV afterload. What the right ventricle actually faces is impedance, which is a more holistic and integrated concept. It's all the resistive, capacitive, inertial, pulse-reflective properties of the pulmonary vasculature. And actually, it requires a lot of the power of the right ventricle as it contracts to overcome all of those elements simultaneously. A couple comments about why that's the case. So we know in the afterload in the systemic circulation in the aorta, a large vessel compliance accounts for about 80% of that compliance itself. The small vessels only about 20%. Vascular resistance is in the small penetrating arterioles throughout our body. There are actually many more arterioles in the lungs that are of the same size than there are actually in our systemic arterial circulation. There are wave reflections that add to the pulsatile resistive load, which creates in part the dicrotic notch that we see in aortic pressure tracing. As we age, things get stiffer. There's an increased pulse wave velocity with aortic stiffening that we're all well aware of. That results in elevation of left ventricular afterload. The compliance is independent of resistance, relatively speaking, in the systemic circulation. The pulmonary circulation, not only anatomically very different, but the distribution of compliance is markedly different. It's evenly distributed across the pulmonary bed. The peripheral or distal vessels are responsible for most of the compliance, rather than the large conduit vessels, if you will. So at least 50%, and most folks think 70 to 80% of the small vessels confer compliance on the pulmonary circulation. The large vessels, a much less contribution. So in that setting, how do we measure RV function? Well, the gold standard still is pressure-volume relationships. You have actually a cardiologist here who I had the pleasure of having dinner with last night who has a very sophisticated manner of measuring pressure-volume loops in the circulation. We talked about the clinical applicability, but I think as a conceptual model for how we approach disease states, it's still critically important to understand the fundamentals. And there are three domains, if you will, that pressure-volume relationships reside. First, there's end-systolic elastance, which is a load-independent measure of contractility. There's a way to assess the total lumped afterload, which takes into account not only the resistance and capacitance, but the pulse wave reflections and the inertia of blood. That's called lumped afterload. And finally, that has to be coupled together, right? That's really what the heart is supposed to do, is to couple its contractile response to the prevailing load on a beat-by-beat basis. Well, let's talk a little bit about the right ventricular pressure volume loop. It looks different than the left. There's not really truly isovolumic contraction and relaxation in the right ventricle. As you can see, actually, RV volume increases during isovolumic contraction modestly because of the low pressures, low impedance, and the constant return, actually, of venous blood. Tricuspid valve closes, the onset of systole, pulmonary valve opens, pulmonary valve closes, onset of diastole. The cycle begins again with the opening of the tricuspid valve. Stroke volume is just the difference, obviously, between those volumes. Well, afterload, at least on the PV loop, is really the wall stress faced by the right ventricle during the ejection phase. It's that portion from opening the pulmonary valve to closure of the pulmonary valve. That's occurring throughout ejection. End systolic elastance, which is a load-independent measure of contractility, has to be defined over a range of pressure volume conditions, and it's the slope of the end systolic pressure end systolic volume relationship, end systolic elastance, which we'll see repeatedly in some of the slides to follow. That's load independent, a measure of intrinsic contractility of myocardial tissue. How do we measure the lumped afterload? Because this is a measure of volume. Well, actually, you can do that with relating end systolic pressure to the stroke volume. That's termed effective arterial elastance, or arterial elastance. That accounts for both the resistive and pulsatile loads. And what happens actually in the attacked heart is just this, that the effective arterial elastance, or net load, is coupled to the prevailing state of contractility to allow the ventricle to return to the same set of ideal normal resting conditions, obviously to normalize wall stress and maximize contractile function and ejection. That's a measure, then, of right ventricular pulmonary artery coupling, the ratio of end systolic elastance to effective arterial elastance. So how does the RV under normal conditions work? Well, it preserves that ratio. So in a normal RV under increased load, either pressure or volume, in this case pressure, it will increase its contractile state intrinsically, reflexively, to meet that increased load. It'll preserve the ratio of elastance to, end systolic elastance to effective arterial elastance. Coupling is preserved, and the ejection fraction stroke volume is maintained. A diseased right ventricle is not capable of doing that because it's not able to augment its contractility normally. So the ratio between the contractile response and the effective arterial elastance is reduced. It declines typically. This is an instance in which the right ventricle and pulmonary artery is uncoupled. The only fate is that over time, right ventricular pressures will rise, cardiac output may eventually fall with an increase in pressure and or volume overload. There's evidence, this is one of many studies, inhaled nitric oxide in 8 patients who have pulmonary hypertension, that even the chronically loaded right ventricle can adapt to this somewhat. So causing a reasonably significant reduction in pulmonary vascular resistance and altering capacitance, which happens whenever resistance is reduced, does cause an increase in stroke volume and cardiac output. It affects better coupling. So it's one instance of how reduction in pulmonary afterload affects better, more normal, if you will, RV to PA coupling. It also gives us insight into why measures like right ventricular ejection fraction, fractional area shortening, or ejection by echo, and TAPSE are actually also afterload sensitive. We'll develop that in a little bit longer. A critical contribution to pulmonary load is what the left heart is doing. And there's been a lot of actually very important work over the last decade or so remapping the contribution of the pulmonary circulation to the right heart. That's best described as the inverse hyperbolic relationship between arterial compliance and pulmonary vascular resistance. When the wedge pressure, obviously the reflection of left ventricular pressure, is reduced, you can see that the pulmonary vascular compliance increases disproportionately to the reduction in pulmonary vascular resistance. It's been shown actually across pulmonary vascular disease states of diverse etiology that this hyperbolic relationship is preserved. It's just shifted up or down based on left heart filling pressures. Actually, the product of compliance in PVR, the RC time, is relatively invariant across different diseases. What affects it, though, is what the left heart is doing or isn't doing. So how does that affect the PV loop? So this is a right ventricle laboring, if you will, with a pulmonary capillary wedge pressure of 20. The elevated wedge pressure lowers compliance that we just saw. The PA pulse pressure increases, RV afterload is higher than you'd predict from PVR alone. That's the resultant effect on the pressure-volume relationship. And remember, when you inscribe or integrate the area of a pressure-volume loop, that's actually ventricular work. So the ventricle is being asked to do more work. This is another example. This is a patient who has a wedge pressure of 10 compared to a patient who has a wedge pressure of 25. Obviously, the pulmonary artery pressure has to rise. The transpulmonary gradient is the same. The cardiac output is the same. The PVR is actually the same. But note that the work that this ventricle is being asked to perform is twice as great, roughly, than with a wedge pressure within the normal range of 10. How about a mixed picture where there's a combination of volume and resistive load? In the previous example, the PVR didn't change. In this example, the PVR does change. That increases work even further, where to eject a sufficient stroke volume, there has to be an increased augmentation of work towards the latter part of systole. That may correspond to the notch often seen in the pulmonary arterial velocity envelope in patients who have severe pulmonary hypertension. Well, let's talk a little bit about the development of pulmonary hypertension given its important role in both HFrEF and HFpEF. As we know, the most common cause of right heart failure is isolated postcapillary pulmonary hypertension due to left heart failure, either HFpEF or HFrEF. It's relatively uncommon to have pulmonary venous disease, but not uncommon at all to have some component actually of precapillary remodeling with chronic either HFpEF or HFrEF. A lot of evidence to that effect due likely to decreased nitric oxide availability, signaling, vasodilator capability, overproduction of endothelin, actually some anatomic factors such as compression lymphatics, and the obvious effects as we developed on compliance in the setting of increased PVR. This is just another example, but in a large cohort of patients from Cleveland Clinic, showing that patients, based upon difference in wedge pressure, will have an upward or downward shift of this curve with actually no change, if you will, in the slope of the curve. Those relationships are partially predictive with some clinical utility that gave rise to the hypothesis that these measures may provide prognostic import in patients with heart failure of either reduced ejection fraction or preserved ejection fraction. The compliance is usually measured as the stroke volume divided by the proportional pulse pressure of the pulmonary artery. Well, no surprise that the pulmonary wedge pressure impacts the arterial elastance, the concept we developed previously that is effective lumped right ventricular afterload. So if one plots the pulmonary arterial wedge pressure against the right ventricular effective elastance, you see that there's a relatively linear relationship that is different according to different PVRs. So the higher the pulmonary capillary wedge pressure, the higher the lumped afterload. No surprise there. What's been valuable, this is a recent study published by my colleague at MUSC, Ryan Tedford, and colleagues at both at Hopkins, Mayo, and Northwestern, in about 1,000 patients who had both HFpEF, HFrEF, and mixed kind of etiology of heart failure, is that when you look at the hazard ratio, which is all-cause mortality, there's much more predictive information in those measures of right ventricular lumped afterload, like effective elastance and PAC, than there is in PVR, transpulmonary gradient, and diastolic pressure gradient between the wedge and the pulmonary diastolic pressure. And in fact, the C statistic under the curve for all-cause mortality mortality, again, far superior to those measures of right ventricular lumped afterload. This is a critical determinant then of the fate of our patients who have any type of left ventricular dysfunction. So let's talk about the at-risk RV. The at-risk RV is essentially every RV that's coupled to a heart that has HFpEF or HFrEF. Obviously, the underlying heart failure syndrome may affect the right ventricle. There's a lot of evidence that that's the case in HFpEF and in HFrEF. That can be due to a combination of factors, including ischemic injury, non-ischemic injury in non-HFpEF patients. It's been known for decades, actually, that right ventricular function here as measured by ejection fraction is important in determining the prognosis in patients who have HFrEF. This was one of the better studies done by Guillot et al. In Italy, where there were 4 different quartiles of patients, depending upon pulmonary artery pressure and preserved REF. Not surprisingly, the patients who had a high pulmonary artery pressure and low REF, who have the worst RV-PA uncoupling, presumably, have the worst prognosis by far. And no surprise that in a large cohort of patients with HFrEF, low PAC, which means typically PVR higher, is not only associated with RV dysfunction and mortality, but actually determines the overall outcome of a patient. Because the pulmonary arterial compliance bundles, again, the effects of PVR and left-sided pressures on RV afterload. What's been interesting recently is that this also appears to be prognostically important in HFpEF. So this is one relatively small series, but it's been duplicated in other studies, where pulmonary arterial compliance predicts outcomes in heart failure with preserved ejection fraction. So it begs the question, is this a signal that the right heart is prognostically important in HFpEF? And it likely is. So this is a recently done study in Germany of RV function in early mild HFpEF, RV contractility, and RV stiffness based on pressure-volume relationships were both increased in early to mild HFrEF. These are patients who had normal cardiac indices, normal right ventricular ejection fractions by MRI and echo, and had mean arterial pressures of 25. Their ratio of elastances was 1.6. As heart failure with preserved ejection fraction gets more symptomatic and advanced, actually right ventricular function declines. Right ventricular, both stroke work reserve, which we'll develop in a moment, and actually right ventricular functional area change both decline, in part due to what's happening in the pulmonary circulation due to chronic elevation of left heart pressures, likely also due to endogenous biochemical or metabolic signaling pathways that are also altered in the left ventricle. This was one study actually from Barry Borlaug at Mayo, where RV function was found to be much more impaired in more advanced HFpEF due to a combination actually of contractile impairment, afterload mismatch, associated with increased pulmonary pressures, male gender, atrial fibrillation, and more adverse markers of ventricular interdependence. So again, a cautionary note that that sweet spot is important because the ventricles are always working in concert as best they can. If one is too aggressive in unloading the left ventricle, that can lead to actually a leftward septal shift, a dramatic reduction in septal function, and a less productive part of the Frank-Starling curve. So as clinicians, we wrestle with this on a frequent basis. And I just want to give a couple of examples of where this can be the most challenging. One of the instances is in cardiac surgery. So this is data in 9 patients undergoing CABG who had pulse wave tissue Doppler signals that were decreased within 3 minutes of incising and opening the pericardium. They were normal during the initiation of cardiopulmonary bypass. It appeared that incising the pericardium was the culprit, if you will. That reduction in S prime remained depressed throughout the entire course of the operation. And actually, there are some longer studies where S prime is reduced longer term after cardiac surgery. This is another series in a cohort of normals, patients who underwent heart transplantation, patients who underwent coronary artery bypass surgery, and lung transplant, where there's some abridgment of the pericardium but not complete stripping. And the authors argued that this underscores the importance of the pericardial constraint on optimizing ventricular interdependence and interaction. Patients who have lung transplants don't have the same stripping of the pericardium, they have opening, and they fell in between normals versus patients who had more extensive pericardial strip. This is a complicated slide, but it's important because it integrates what happens to the RV after VAD implantation. And this was an editorial written by one of my junior colleagues, Brian Houston. So Brian and Ryan Tedford conceptualized there are 6 factors that impact right heart function after VAD implantation. The first, possibly due to pericardial constraint and also the loss of torsional movement in the septum in an unloaded left ventricle. The right ventricle increases its venous return, which it has to because the VAD usually increases cardiac output. The afterload in the pulmonary circulation is almost always reduced if we set the VAD properly. So despite this increase in preload and reduction in afterload, the ventricle often still struggles. It's thought that it's a change in intrinsic RV contractility that confers that. As shown in 1A here, the normal longitudinal motion post-VAD is markedly reduced, and so the ventricle is more dependent on this transverse shortening that has a finite limit because there's just not enough mass of the ventricle, and it's a relatively inefficient way of impelling blood without that torsional impelling motion we developed early on in the talk. The LV torsional ringing motion, so important to empty the LV, and also the LV is less important because the ventricle now is unloaded. The ventricular volume also reduces itself, the septum shifts. That's adverse often for the right ventricle. The third factor is, again, that the reduction in RV contractility, largely reflecting the reduction in LV contribution, challenges the right ventricle. The LV, contractile performance, declines. That's the whole point of implanting an LVAD. Fifth, there can be constraint of the heart. The heart is suspended from the great vessels. It's designed to twist and lift. That's what causes the PMI, right? When that's lost, there's some incurred mechanical inefficiency to ejection. There's a lot of adhesion and other things that happen, particularly in LVAD implantation, and there's a large cannula that's placed through the pericardium with continuous flow VADs that pinions the ventricle in a way that was never designed. Again, the heart is suspended. It's meant to be freely mobile in the chest. That's one of the ways it adapts in the setting of appropriate pericardial constraint to shifting volume and load. And that's been shown in a different model that's also elegant. This is pulmonary hypertension, but actually it's a Langendorf-like preparation where the left heart is bypassed. It's taken out of the circulation altogether, and no surprise, just like we see frequently in our VAD patients, this is right ventricular pressure-volume relationships. The dark is pre-institution of LV bypass. The light gray is post-implantation of LV bypass. Contractility declines, and the ventricle dilates. You can see here that the contractility during LV unloading of the right ventricle declines sharply, as does the stroke volume work. More indication of the importance of interaction. So just to summarize this part of the talk, hopefully we've developed the concept that RV depends on LV function for a significant portion of its function. That's determined by coupling of contractility to load. Left heart failure, either HEF-REF, HEF-PEF, leads to significant increases in RV afterload, and virtually all LV pathology puts the RV at risk. Well, let's turn a little bit to tools for clinical assessment. It's a challenge because of the anatomic complexities of the RV that we've talked about, and because of the load dependence of virtually all commonly derivable and often usable indices of RV function. If we could, we would best measure RV function, actually, in pressure-volume relationships, but that's not quite adaptable yet to the clinic, so we have to rely on best second-generation measures, if you will. RV ejection fraction, we'll talk about each of these briefly, RV fractional area change, TAPSE, the velocity of tricuspid annular motion, and some hemodynamic measures. This is a recent review, and I would recommend all the fellows actually in the audience and the attending physicians read this review. It's well done. It was recently a position paper by the American Heart Association published in Circulation about actually assessment of RV function and treatment. These are the hemodynamic indices that have been developed in assessing RV function. Right heart failure, remember the central venous pressure, upper limit of normal is 8. It's actually recommended now in this algorithm that any pressure above 8 to 12 be considered for therapy, but clearly RV failure should always be considered present in the absence of some other explanation when the central venous pressure, right atrial pressure exceeds 15. Typically, the right and left filling pressures have a predictable relationship. Even in severe
heart failure with reduced ejection fraction with aggressive therapy. The ratio of pressures tends not to change a great deal if patients are markedly congested and are markedly decongested with diuretics, afterload reducers, even inotropic therapy. But once that ratio alters itself, this is the Cormos index, and this is a different index developed in acute MI, that's a signal for intrinsic right ventricular dysfunction. The RV pulsatility index, which is just the pulse pressure divided by the right atrial pressure, has been shown in some models. The RV stroke work index we'll talk about in a little bit more detail. PVR and compliance we've developed in much more detail. This is what we do in practice, and the important part of this slide is that all these are load dependent, and actually it's a little bit older slide. I would probably put 2 pluses for IVA certainly at this point in time. Normal RV ejection fraction around 60% or so, fractional change greater than 32% is normal. They intercorrelate reasonably well. TAPSE, as we know, which mostly reflects longitudinal shortening, has been shown to have some prognostic value, but it's limited, as we've seen in cardiac surgery, because that intrinsically alters longitudinal shortening in some other cohorts. The Doppler tricuspid valve velocity, annular velocity, quite load dependent, as is measurements of strain. The right ventricular myocardial performance index has been shown to be slightly less load dependent, but still not reliable under all conditions. DPDT is notoriously load dependent. The time to maximal velocity divided by the time to peak velocity, the so-called isovolumic velocity index, is promising, but also more load dependent was anticipated. And maximal elastance remains our gold standard, but it's difficult. Just a couple of quick comments about TAPSE. First, realize that it's not only load dependent, but it doesn't account for transverse shortening, which may be more important after longitudinal shortening has been affected by diverse causes that we've partially developed. It obviously is important. We use it at our center, but we integrate it with every other measure, including RV fractional area change, RV ejection fraction, measures of hemodynamic import, and use that in an integrated way to try to make decisions. RV stroke work index, we calculate in our program. Like you, we have an active VAD and transplant program before every VAD implantation. There are innumerable risk models pre-VAD implantation that have been derived, most of which include RV stroke work index. The problem is that none of them appear to perform particularly well because so many things happen both as we've developed in the operation and afterward that even patients who have a relatively preserved RV stroke work index heading into a VAD can get into deep trouble relatively quickly. But it is an important marker. When we have patients in our ICU, at my center, we have actually a display of all the pressures, the filling pressures, the wedge, the cardiac output, and I asked my fellows, what are the 2 most important pressures displayed on this ream of information? And no one picks RV stroke work or LV stroke work index. If you start being attentive, you will notice that patients admitted with advanced heart failure who have pulmonary artery catheters will almost always have an LV stroke work index that's about 20% of normal. You can almost bank on it. RV stroke work index is highly variable, dependent upon load. And one of the gratifying things to do with hemodynamic tailoring in those patients is to see what interventions appear to affect RV and LV stroke work index. That's what the heart's designed to do. It's a compressive pump. Blood's not very compressible. It applies work to try to eject blood out of itself. In terms of cardiac imaging, RV ejection fraction itself load dependent. There is a good correlation between the gold standard for RV ejection fraction, which is MRI, and fractional area change, as long as the echocardiographic indices and windows are interpretable. TAPSE, as you can see, has reasonable correlation with markers of fractional area change and RV ejection fraction. Peak velocity, particularly if it's depressed, is valuable, and RV strain imaging, which we don't do routinely in our center but are developing as a research tool, again because of its load dependency, may hold some promise when integrated with these measures. What no one has really done extremely well yet is to integrate these with a kind of agnostic machine learning approach and see how these might incrementally provide more clinical precision. We've talked about most of these things already. I would just point to the last bullet point, which is that exercise hemodynamics can be helpful. There's increasing literature that RV physiologic reserve that can be measured in a variety of ways, both invasively with differential pressures or actually non-invasively by exercise echo can be prognostically important. And we'll develop some of the studies here in a minute. Cardiopulmonary exercise testing is not really sensitive or specific, unfortunately, for RV dysfunction.
despite having done some work years ago in the field to establish the importance of RV ejection fraction, but there's nothing specific, unfortunately, typically in the results from formal cardiopulmonary exercise testing with peak oxygen consumption that points to right heart failure. Well, let's talk about some of the other indices that are a little bit more palatable. There is value in the ratio of TAPSE to pulmonary artery systolic pressure as a marker likely of RV reserve. So you can see in this study in a large number of patients from Italy, Marco Guasi's center, that patients who had the most reduction in TAPSE divided by pulmonary arterial systolic pressure had the worst outcome. It's likely an important marker of contractile dysfunction, if you will, and RV uncoupling that can be done echocardiographically. And we do use that in selected patients. Paul Forfia has suggested a couple of other measures that are obtainable by echocardiography. TAPSE combined actually with notching in the pulse wave Doppler RVOT signal. That's a fairly highly specific sign of increased PVR, and so patients who have primary RV dysfunction will have actually a lowish TAPSE and will have notching. So it recapitulates what was shown actually in the early RV studies of high PVR, low RV ejection fraction in part. This is another suggestion from Dr. Forfia that you can actually match TAPSE to the PVR in patients who have a nearly synchronous right heart catheterization, that there's an expected range of mappability of PVR to TAPSE, and that patients who are unmatched, as shown in panel C here, who have a high PVR but a lowish TAPSE, are those who are most likely to be uncoupled, all the caveats of load resistance notwithstanding. So the gold standard, obviously, as we developed, is PV looping in these patients. This is what it would look like if we were to do it. We actually do this for research purposes at our center, as you guys do here. But this has yet to translate into clinical applicability, mostly because it's not been shown yet to have a designated effect on a clinical outcome of importance. But it probably does, at least with prognostic predictions. So this is data from Dr. Tedford, that pulmonary volume relationships, again, the relationship of elastances is more predictive than right ventricular ejection fraction, at least in patients with pulmonary arterial hypertension. And there's a lot of interest now in defining right ventricular reserve as yet another prognostic marker. And one can actually relate ambient, if you will, ventricular coupling to RV reserve. It's actually been shown that relative RV stroke work reserve is actually a linear function of the ratio of the elastances with a reasonably good correlation of 0.74. And we can measure that in a variety of ways. This was done with echocardiography. Patients had actually either augmentation of their pulmonary systolic pressure or not. That was related to their peak VO2. There was a relationship of both that defined terciles of prognosis and outcome. So the ability to augment pulmonary artery systolic pressure by echo with exercise is a prognostically valuable thing, particularly if it's greater than 30 millimeters. The inability to do that associated with a less prognosis and a lower peak VO2. And when you combine both of those factors, so cardiopulmonary exercise testing with echo-derived measures of pulmonary systolic pressure shown in this slide, you get additive information. So if both of those adverse factors are present, if you will, that marks even a higher risk tercile or cohort of patients. This is an interesting study where RV ejection fraction may have some import on coupling. So survival in this cohort of patients with pulmonary hypertension was predicted by baseline RVEF and PVR. Patients were then treated for a year with pulmonary hypertensive therapy, and it was shown that a decline in RVEF at 12 months, but not the decline in PVR, was what determined prognosis. Very interesting observation from the pulmonary hypertension world that the long-term fate of patients is dependent not on PVR, it's dependent on RV function, and that's been shown in many studies over time, actually. It also provides opportunity to do a simpler assessment of elastance couplings because ejection fraction, which is stroke volume over end diastolic volume, can also be defined as this relationship. And as my colleague Ryan Tedford, who's a very careful thinker about hemodynamics, tells me, that holds true, Tom, but only if the volume intercept is 0, which unfortunately it's not in patients who have pulmonary hypertension and left ventricular overload. So this is still an assumption-laden assessment, but it comes close with the importance of stroke volume over the volume at end diastole as being proxy, if you will, as a measure for RVPA coupling.
And this is another example of the importance of RV function. These are patients who have idiopathic pulmonary hypertension. Again, the patients who had progressive declines in RV function were the patients who did poorly. The patients who don't actually tend to do well with a stable event rate. Again, that's been shown in cohort over cohort. There is some information in RV ejection fraction, it's just limited by load. So to summarize this portion of the talk, our measures of RV function unfortunately suffer from load dependence. They're not yet true measures of RV-PA coupling, but I hope to give some snippets actually of insight into non-invasive ways that RV-PA coupling could be measured. Pressure volume assessment is the gold standard. At some point, it will likely be feasible in clinical practice, particularly if we can derive outcomes from it. And RV reserve may predict RV coupling and may have additional prognostic value. Just in 5 minutes, I want to talk briefly about therapeutic considerations, leave a little bit of time for questions. So the cardinal principles are reducing RV afterload, lowering left atrial pressure, treating whatever precapillary component there may be, increasing or at least optimizing RV contractility, optimizing septal function and position, and ventricular interaction. The recent position statement from the AHA, a somewhat disheartening conclusion that pharmacologic mechanical interventions targeting isolated acute and chronic right heart failure have yet to be investigated. Specific therapies are lacking. So prudent understanding, I think, of the physiologic principles and translation of them on a case-by-case basis is what's critical in this condition. That's why I've tried to develop those concepts in some detail. This is the algorithm that's not only difficult to follow, but somewhat simplistic because this is unfortunately the state of the art, that we optimize preload after we look for other reversible causes. The optimization should be to reduce the CVP to normal whenever possible. Lynn Stevenson did work decades ago at UCLA arguing that reducing left heart pressures to as close to normal as possible and as tolerated in a given patient was always the best thing to do in left heart failure. Likely the same is true in right heart failure. There's not a lot of recruitable stroke work reserve that's been shown in animal models when the CVP is greater than 12 to 15. It just causes more adverse ventricular interaction. So a relatively aggressive recommendation to reduce central venous pressure and right ventricular preload to as close to the normal range as possible, obviously with diuretic therapy and vasodilators as possible, and then a fairly aggressive movement to inotropic support if necessary. Again, can't underemphasize the importance of the left heart and its interaction with the right heart, given this inverse parabolic relationship. So the guidelines, although this is an older slide, is still the case that decreasing passive congestion pulmonary pressures are critical. Guideline-directed therapy, diuretics, most of the benefits from vasodilator therapy is due to unloading the RV. The studies in pulmonary arterial specific therapies have been disappointing. We're going to review a little bit of that data, particularly in HEF. And so the routine use of pulmonary arterial hypertension agents is not recommended now. This is data from RELAX, which was a well-done randomized placebo-controlled trial in HEF patients, elevated BNPs, typical cohort for HEF-PEF. They're randomized to sildenafil versus placebo. It was a completely negative study. There was no improvement in any of the primary endpoints, which was mostly peak oxygen consumption at 24 weeks of therapy. That was despite a reduction in systemic LV afterload, an actual somewhat surprising reduction in LV contractility, perhaps due to the Antwerp effect because of the reduction in load. But even more discouragingly, there was no difference in pulmonary arterial pressure, RV load in a sub-study, and particularly in patients with RV dysfunction who had impaired RV-PA coupling. There were no improvements actually in any of the endpoints in that unfortunate cohort of patients. So these therapies, even in HFrEF, have yet to be shown to benefit the right heart, including PDE5 inhibitors. There have been small studies that there's an increase in hemodynamics exercise capacity. There's really no study that it selectively benefits the right heart. Endothelin receptor antagonists, we know in HFrEF are associated with adverse effects on hepatic function. They're contraindicated, and none of the other evolving studies have either gained traction or they've actually been shown to be harmful in left ventricular HFrEF. Hydralazine isodil does have an effect on reduction in pulmonary vascular resistance. It's approximately equivalent to nipride. I think all of us exploit that when necessary, but it's difficult for long-term therapy in patients. And inotropic therapy does have a role. The studies that have looked or randomized patients to dobutamine and milrinone have been unable to show a specific difference. Milrinone is an inodilator, tends to be associated with more hypotension, but both milrinone and dobutamine have modest effects on pulmonary vasodilation. More prominent the sicker the respective ventricles are. Dobutamine will cause some degree of pulmonary relaxation, which in some studies, at least in HFpEF, is probably actually how it works. So an interesting study, patients who had fairly advanced HFpEF were given either dobutamine and then compared to controls. You can see in controls, dobutamine increased the tricuspid peak velocity, S prime, as a function of any prevailing mean pressure. In HFpEF patients, it didn't. Meaning that in HFpEF patients, dobutamine did not really appear to have an inotropic effect. It appeared to have a vasodilatory effect because actually some other load-dependent measures of ventricular RV function improved, like the S prime and DPDT. Very interesting result that in advanced HFpEF may not be a lot of recruitment of contractility, but important effects, hopefully, with vasodilators. So just summarizing the little bit of literature that's available, dobutamine tends to restore RVPA coupling, likely because it's vasodilatory. Milrinone does increase RV contractility, as to some extent dobutamine probably does in systolic RV dysfunction that's more advanced, certainly lowers PVR. The combination inhaled nitric oxide we use not infrequently in patients who we need to rescue. PDE5 inhibitors may have RV inotropic effects on hypertrophy RV. That has yet really to be conclusively shown, actually, and we saw the effects, actually, at least in HFpEF studies. Oops, pardon me. So with that, I'd like to end. I know there was a lot of content. What I hope to do is to review some of the principles underlying the diagnosis, the clinical approach, and therapy. These are my colleagues at MUSC. I am deeply indebted, particularly to Dr. Ryan Tedford, who is here, who joined us 2 years ago, who's one of the world's experts in right ventricular physiology and pulmonary hypertension, who contributed many of the slides to this talk, and to my colleague Brian Houston, who actually wrote the editorial summarizing the multiplicity of effects on RV function after VAD. With that, I thank you for attention and be happy to take a few questions in the few minutes we have left.
Dr. DeSalvo, thank you so much for that enlightening talk. Certainly, this is an area that, like I said, whenever we round, literally every single patient has some form of RV dysfunction that is a problem, that is perturbing their outcome. And, so while the questions are forthcoming, so one thing I think is definitely more data coming out on our wide use of sildenafil. I mean, lack of a treatment, but this problem being so widespread, and now we are learning that perhaps its benefits that we were hoping may not be so evident, and with our valve patients and in our HFpEF patients. So, I just wanted to share your thoughts. If you consider all the physiological items that you outlined in PVR and definitely contractility, what element do you think that, one, we are not targeting appropriately, and two, specific to sildenafil, what are your thoughts as far as the potential benefit or harm that we may be incurring on patients in our utilization that we're doing now?
I agree. It's a really important question. I think if one follows the best evidence that we have from randomized clinical trials to date, there really appears to be little, if any, benefit to sildenafil therapy in either left ventricular failure from reduced ejection fraction, albeit the exercise trials, or actually heart failure with preserved ejection fraction. There really, unfortunately, appears to be little, if any, effect on RV intrinsic function. Sildenafil is a pulmonary vasodilator, but as we saw, given the inverse hyperbolic relationship between pulmonary vascular resistance and compliance in left heart function, it's much more complex than just targeting simplistically a reduction in pulmonary vascular resistance, because the integrated physiology is so different. I mean, even if you reduce that but unload the LV more than it should be unloaded, we could be theoretically adversely affecting the right heart. Sildenafil tends to reduce left ventricular pressures and volumes, but there's a sweet spot there that we actually don't understand and don't personalize in our therapy.
that I think is the Achilles heel. We tend to be aggressive in pharmacologic therapy rather than settling for just enough, and we don't actually set the hemodynamic parameters in the heart with our pharmacotherapies appropriately. I think we do know that certain signaling systems have to be blunted. The beta-adrenergic signaling system, the aldosterone system, the angiotensin signaling system. But if you obliterate them, that's harmful. You know, there are a lot of drugs that have never come to light, trials that are stopped early because of excessive pharmacologic sledgehammering, if you will. And sildenafil nitric oxide is a critically important molecule that does its best. You know, I was, this is a little bit of a tangent, but I was always surprised when the Zeritide came into being, because giving more of what's already an upregulated hormonal system and factor was counterintuitive to what we do with the neurohormonal antagonist when we treat chronic heart failure. And lo and behold, it probably doesn't have much in effect. So I see sildenafil as similar in some ways to Zeritide as reaching for a non-specific vasodilator that doesn't have any neurohormonal protection, shutting down the adverse biological signaling that actually determines the fate of the heart. So if I had to bet a nickel, it's because sildenafil is just, it's a non-specific vasodilator. It's like hydrolysis.
It's not as selective as we initially was.
And it doesn't blunt the biological mechanisms that cause heart tissue become even more injured and incapable of supporting the prevailing load. To date, the only things we know that do that block the adrenergic nervous system, the renin-aldosterone system. Beyond that, we're just kind of, in plain English, gussing up the hemodynamics a little bit. But we knew that from lots of other studies in the past. You know, it's not difficult to reduce load. The issue does the reduction of load translate into a meaningful clinical benefit to the patient? And the answer is not always. There has to be reduction of load plus something else that either restores or retards progression of what appears to be a fairly inexorable process in the tissue once patients are diagnosed. And just another comment, by the time heart failure presents clinically, it's a very late stage of the disease. We go through our entire lives with tremendous reserve and resiliency in our cardiovascular system. Once the system fails, it's a very advanced stage. And we lose sight of that. We nudge it back. We don't cure right or left ventricular failure. We nudge it back. We retard progression. But anything that's not retarding progression based on a molecular mechanism is not in the long run going to be beneficial. So I don't see that there's that mechanistic link to nitric oxide signaling that determines the fate of myocardial tissue.
A lot more work to be done.
Yes, sir.
Mark?
Dr. Salvo, it's an excellent presentation. I had a few questions. It may be short of time. I can maybe lay them out, and maybe we can talk offline. The first one was that your idea about intact LV function. So for patients who are lung transplant, pulmonary arterial hypertension, that we do double lung transplant, invariably have severely dilated RVs and RV dysfunction, but almost all of them get better after double lung transplant, probably because they have intact LV function, as opposed to heart failure patients who have a bad LV. I'm assuming, I'm just me, but clinically we see that they all get better. The other point I wanted to ask you, you didn't mention in terms of the mechanism of RV dysfunction, rhythm control, because if you're in atrial fibrillation, you lose your longitudinal RV function as evidence of lack of atrial contraction and annular motion. So if there's any role of rhythm control in terms of treating RV function. And then the last question was, where do you think right now the current recommendations to keep a midline septum when you're optimizing LVAD speed, where do you think where the LV septum should be? Should it be bulging slightly into the right ventricle, or what are your thoughts about that, and what are your thoughts about maintaining CRT after LVAD implantation?
Those are all great questions. I mean, if I can recall them in order. So the first comment, the resiliency of the RV, there are kind of lusus naturae, so there are freaks of nature where the RV, if it doesn't undergo the adaptation after birth, where it involutes much of its mass, it actually can sustain almost systemic, near systemic loads for decades. Corrected transposition is a great example. My own personal take without any evidence is that the RV is designed by nature to be more resilient in some ways than the LV, because it's got to respond minute to minute to changes in stroke volume and immediately adapt. And no one's explored that, whether the resiliency to injury, the fibrotic reaction in the RV, whether, as Doug Mann and others talked about, the RV passages through a period where it crosses the Rubicon, you can't recover it, probably, but no one's really explored that. And I think the adaptation to load, as long as you restore the load, it's just like the dog model, where you can cauterize the right ventricle but sustain a circulation even if the RV is damaged, which would never sustain the left-sided circulation. So there's a huge advantage in the right heart, probably teleologically engineered, as long as the afterload is low. The second question about rhythm is important. It's not, to my knowledge, been really rigorously tested. There's probably less contribution just given the relative passive components of RV filling relative to LV filling with preservation of atrial systole, but no one knows that for certain. The desynchrony is a real aspect. We actually just had a paper from our EP group in VAD patients suggesting that actually preservation of synchrony by CRT post-VAD anyway is important to try to synchronize LV and RV contraction, and certainly the state of desynchrony incurs contralateral challenges to RV ejection. There was another question too. The septum position, yeah, in VAD patients. That's a great question. And so, and I hate to say there's no easy answer, but in general, we try to arrive at left ventricular end diastolic volume of around 4 to 6 to 5. We actually increasingly are taking the pains of doing a hemodynamically guided ramp study with a PA line in place. And echo guidance at the same time. It's a little laborious, but I've always been surprised when we do random surveillance right heart casts, up to 25 to 30% of patients are not unloaded with their left ventricles, although they appear to be and appear to be functioning well. They walk around with left heart pressures of 30. Because the heart's not pulsatile, they don't have those incursions of higher pressure and develop acute pulmonary edema, but they're fading and failing, and their right ventricles are at risk. It's actually surprising to me that the long-term RV failure, as poorly described as in the literature, is only about 10 or 15% long-term after a VAD. My experience is a little different, perhaps because of the spectrum of patients that we're implanting. But we've been moving actually much more aggressively to true hemodynamic optimization of LV load, with trying to maintain what we think is the physiologic normal septal pattern. And sometimes we've actually reduced speeds to recruit more contractile function of the septum.
So how are you gauging that? You're just looking at septal position, or?
Ultimately by the hemodynamic response to the patient, actually, with pulmonary artery catheter guidance. So we actually exercise them and look for the ability to augment stroke work in cardiac
Dr.
output.
Salvi?
Enjoyed very much your presentation. Thanks
you.
for coming. How come does the right ventricle adapt nicely to a gradual increase in pressure as opposed to an acute? Is this all because of normalizing stress and hypertrophy that we can detect well? Is there some other adaptive mechanisms that we do it that we may not be cognizant of? What's your thoughts on that?
That's a great and very important question, actually. So it's clear that the right ventricle, if progressed with a steady, non-acute increase in load, can adapt actually beautifully and sustain, in some patients, even systemic pulmonary arterial pressures without symptoms or overt signs of right ventricular failure. I think both ventricles have that capability, and this is just more philosophizing than data-driven, but actually in utero, the respective ventricles have the same mass. The RV actually is thought to contribute more to the output of the fetal circulation than the LV is, because the LV is not coupled to the pulmonary circulation. And at birth, with the reduction in vascular resistance, things regress. It's built into the epigenetic machinery of right ventricular myocardial tissue. And likely, the reverse can happen to some degree, which if slow load is opposed, some of that neonatal involution actually recapitulates itself. So there's also evidence, although it's not conclusive yet, that the right ventricular cellular hypertrophy is accompanied by fiber orientation
rearrangement as well that optimizes some of the translational movement and some of the compressive force that the ventricle is able to generate. All that's dependent upon normal left ventricular function likely, but there's more plasticity in the right ventricle to adaptation to chronic load. There's plasticity in the left ventricle as well, but the left ventricle is constrained, one, by its volume, two, by its reliance on torsional movement. So it may well be the mechanics give the RV a selective advantage in load adaptation that the left ventricle can't exploit to the same degree. It's more philosophical than data-driven. No one's really looked carefully at that. What I can say, though, that when folks have looked, because I've looked with proteomic differences, genomic differences by RNA levels, even long non-coding RNA, there's not a lot of difference between the ventricles. So my own hypothesis is actually, the heart is a structural primitive organ, and that the structure determines the fate. And because we can't recapitulate embryologic development, there are going to be certain limitations to what either ventricle can do. The molecular machinery is probably fairly shared and uniform. I always think of the myocytes as, boxcars on a long train. They're managed in part by their intrinsic responsiveness to their prevailing conditions. If everyone wants to take a deep dive, one of the most interesting literatures to read is if you take myocytes out of the heart, how different they are when you put them in a different set of hardness of substrate. You have a different series of contacts. You electrically stimulate them differently. They're very responsive cells to their environment. So once that environment is set and fixed, there's only a certain repertoire of responses permissible. Over time, there's some flexibility in that. And it's probable that the right ventricle has a different and perhaps more fluid ability to adapt to load.
Thank you.
Thank you.
Thank you.